Hello, and welcome to the CARE-TA 2023 State Conference on Crisis and Recovery Enhancement. My name is Jamie Seller. I will be doing a presentation today entitled Crisis Services Yesterday and Today. Here are the disclaimers. The views, opinions, and content expressed in this presentation do not necessarily reflect those of our funder, the California Department of Healthcare Services, or our CARE-TA center partner agencies listed below. The reality is they do reflect my thoughts and opinions, and I represent RI International. So I'll go ahead and introduce myself. I'm Jamie Seller, Chief Strategy Officer at RI International. I am a consultant in the behavioral health space. I am a licensed professional counselor. I've been working 35 years predominantly within crisis systems. I was also one of the writers for SAMHSA's National Guidelines for Behavioral Health Crisis Care that came out in February of 2020, and really is the way that the states are starting to move forward. It's the way the federal government is looking to go ahead and fund and try to operationalize and organize crisis systems so that there is consistency from state to state, county to county, jurisdiction to jurisdiction. I want to go ahead and start off by showing something that came out of the Atlanta phone book, I think in about 1961. For those of you old enough to remember, this is something that was fairly common. Every phone book had this. And what you would do is you would go ahead and write down the emergency numbers that you needed, and you would go ahead and pull that off. And then you would go ahead and put that on to your refrigerator, which was hopefully beside your rotary phone that was connected to a wall. Now, the reality is, as you look through this, very few of those numbers are already filled in because there were a lot of numbers to go ahead and start to call. And really what we'd be looking at is this would be on the next page for that Atlanta phone book, and it would talk about where you were depending on the number that you would call. If you were in Atlanta, you call that 521-2121 number. If you were in Decatur or College Park, you called a different number. Now, the challenge with this is that if you were traveling, you didn't have your refrigerator next to you, so you didn't have your handy dandy guide next to you. You might not know the number because it wasn't ingrained into your brain, or you might not even know the city that you were in. But you did know that you were in trouble, but you didn't know quite how to access help. And it was going to go ahead and be difficult to get a response to come out to you. Definitely not the situation that you want when you are in a crisis. You want things to be simple, easy, and memorable. I want to go ahead and show you how that tends to look now in California for mobile crisis outreach. This is a list that Optum Behavioral Health puts out. They update it. I think it's really good. It supports me as I go into communities to start to determine where are their crisis systems, how easy is it going to be to access those systems. And as we take a look here, we see a lot of different numbers, very reminiscent of the numbers that we would see in the 1961 Atlanta, Georgia phone book, where if you're in a different county, you call a different number. What I also like about this, don't like about this, as we start looking through, is that we start seeing that there are hours of operation or exclusions for when you can go ahead and get help. So really what I start to see as I look through this is I say, depending on what county I'm in, depending what day of the week it is, depending on what time of day it is, my crisis response may get a very, very different response. I might be in a community like Riverside that offers 24/7 mobile crisis teams, or I may be in a different community that only has hours Monday through Friday in the evenings, Monday through Friday in the days, maybe limited hours on the weekends. And at 2 o'clock in the morning, I might have definitively some challenges in going ahead and getting the help that I need. Really, what we look at is a system that is low barrier to access, easy to get into, doesn't have a lot of hoops to jump through. Looks something like this. This is Arizona's. So we can see a big difference between what we're doing in California and what we do in Arizona. In Arizona, I can be in any of our counties and I'm going to get a fairly similar crisis response. The phone number I call is going to be a number that gets me to a statewide crisis and access line, whether I am in Graham County or whether I'm in Maricopa County with its 4.4 million people. I'm going to have the same access to mobile teams. They're going to come out and see me 24/7. It could be Saturday at midnight. It could be Tuesday at noon. I'm going to go ahead and get that response. The only caveat difference that might be is it might take a little bit longer. If I'm in a very rural or frontier area, it might take, 30, 45 minutes of driving to get to where I am. as opposed to maybe 15 or 20 in an urban area. And sometimes with traffic in California, that can get stretched out as well. And as I take a look at the contact number, understand that really what we're talking about is I can memorize that 844 number. Right now, I can also memorize 988 because that 844-534-4673 number actually is going to go ahead and go straight into the 988 dispatch center. So if I dial 988, I'm going to the exact same place as if I dial that 10-digit number. So I want to talk a little bit about the history of crisis services. So what we started to see is a significant change in the 60s for physical health emergencies. And really, the paper that you're seeing here is very instrumental in that. What they went back and they started to talk about was the quality of healthcare, emergency services, ED visits for people that were in a physical health emergency. And what they realized fairly quickly is you were actually more likely to be able to live after an injury in Korea or Vietnam than you were if you were in a car accident in the USA. And part of the reason for that is based on those wars, we had a very specialized way of communicating, of coordinating care, of providing very focused, specific care as early as possible. And this was just simply not the case in the US. What we found was that there was no way to really get an ambulance out there. It was difficult to go ahead and manage. If you did get to an emergency department, there were challenges in getting into the emergency department. Do they admit at night? Do they not admit at night? Is your doctor on the panel that's able to work there? Did they have the technology or the skill set to be able to treat what your issue was? So it was through this lack of coordination or an integrated system or multiple services that really tended to increase the amount of deaths that we were seeing on the highways, especially as more people were starting to drive and more frequently getting in accidents at higher and higher speeds across the country. So when we look at this, part of this paper was the impetus to go ahead and drive 911 forward. We needed an integrated system of care. It should be more likely that you survive a car accident in downtown Atlanta than it is if you're in Vietnam or another faraway place. Here's exactly what they said. Expert consultants returning from both Korea and Vietnam have publicly asserted that if seriously wounded, their chances of survival would be better in the zone of combat than on the average city street. Excellence of initial first aid, efficiency of transportation, energetic treatment of military casualties have proved to be the major factors in the progressive decrease in death rates of battle casualties. And we were seeing this at the exact same time we were starting to see increases in accidental deaths in the US. So out of that, I want to talk a little bit about crisis evolution. Here's a chart that really kind of talks about it. We started the first free 24-hour crisis line in LA County, Dr. Schneidman, 1958. That was low barrier access, people having suicidal ideation, someone to go ahead and call. Absolutely important. In 1987, we started to realize that most behavioral health crisis care was coming in the back of a police car. And as such, the Memphis model of CIT training or intervention training for officers started to gain a lot of traction to go ahead and support those officers in understanding how to work with people in community with behavioral health issues, but more importantly, how to start to organize a system so it's not reliant on law enforcement to go ahead and be able to provide those services. Then we started seeing some jumps. We've got a 30-year history jump here, got a 10-year jump here, and then we really start kind of moving forward as the country starts to focus a little bit on behavioral health issues. So really what we're looking at is behavioral health response actually started having professionally staffed licensed clinicians actually answering service lines for contact for people in crisis. RI, the agency that I worked for, operated living room models, which were drop-off centers for folks that are in crisis, that really had a lot of peer interaction as some of the primary intervention going through. We start seeing these campus of cares in Harris County, Texas, where there's a lot of different services being provided on that same campus. So there really is a no wrong door approach. You can go anywhere on that campus. And if you're not in the exact right place, they're going to help get you to the exact right place. It's probably just a 1-minute walk across a compound. We started seeing direct law enforcement drop-offs here in Phoenix, where the mandate for facilities, crisis facilities in Arizona, Maricopa County was you will take people directly out of the police car. You will not send them to the emergency departments for medical clearance. You will not tell an officer that they need to go somewhere else. You will not tell them that there is a better door for you to come through. And we started seeing dramatic increase in our utilization by law enforcement when we provided them an alternative that would always say yes, just like the other no wrong door approaches in your community, which are going to be your emergency departments and your jails. We kind of run through here, and I won't go through all of them. But as we started to get better and better at doing this, as we started to be able to coordinate care a little bit better, as we started to really kind of lean into the types of services that we offer to provide those low barriers, really what that accumulated into is in 2016, the National Action Alliance for Suicide Prevention commissioned a white paper called Crisis Now. And really what they focus on that crisis now is they brought together 35 to 40 consensus best practice experts from around the country, from academia, from the provider side, funder side, from governments, from peer-run organizations, other stakeholders, hospitals, and so forth, and really said, if we're going to go ahead and create a system, what would it look like? And for inspiration, they started to take a look nationwide at systems that they thought were working. And they landed on Maricopa County, Arizona, 4.4 million people. They landed on Georgia. They landed on how this was all getting integrated in the state of Colorado. And they also had strong focus in some of the work that was going on with call centers in New York. And together what they said is there's no state that's doing this perfect. There's states that are doing it good, and we need to move from good to great. But if we combine some of the elements from these various states, we really create a system that probably is going to be optimized, that ensures that people are getting the right care at the right time. So Crisis Now became a very strong white paper that really most states, most communities were starting to look at as a pathway forward to support people who are in crisis. Eventually, in 2020, SAMHSA took a lot of the ideas from the Crisis Now white paper as far as integrations of systems, low barrier access, strong focus on call center, mobile teams, facility-based, that no wrong door approach, and they created their National Behavioral Health Guidelines for Crisis Care, which was important because now it had the weight of the federal government behind that, which supports a lot of funding to go ahead and move into this as being the next evolution of how crisis care should be delivered across the country, which means in your neighborhood as well. So just a quick overview. We had talked a little bit about the Crisis Now white paper. That had come out of the 2012 National Strategy for Suicide Prevention. Really was taking a strong look at why we had seen an increase of 25% of suicides in the U.S. in the prior 16 years. And really what this paper talked about was lack of access to care. That was the impetus to go ahead and create the Crisis Now white paper, which I spoke about. And as I said, eventually a lot of the ideas in Crisis Now became stronger, more operationalized, better defined in the National Guidelines for Behavioral Health Crisis Care that came through. What was kind of interesting about this 2012 is, as you look through, there were 14 strategic directions and 13 overall goals in this. But the strongest one that we tended to look at was that there should be a provision of evidence-based treatment as soon as possible after suicide risk is identified. And what we've been able to do then is extrapolate that and say there should be a provision of evidence-based treatment as soon as possible after somebody in behavioral health or substance use disorder crisis is identified. So this has really been the moving forward. This is where we are currently. This is, like I said, the playbook that we're absolutely utilizing to drive the field forward. As I had mentioned, the Crisis Now white paper and SAMHSA, they identify that you need 3 strong components within a crisis system to have a system. It can't be siloed. It's got to be very much interconnected. But they focus on a crisis call center. 100% of the time, somebody calls for looking for help at a crisis call center, phone should get picked up. Anybody, anytime, anywhere should have access, regardless of being in rural or frontier areas, to a trained behavioral health person that can support them or help them get connected to the care that they need, or in most cases, help them de-escalate out of crisis and start moving into recovery with some support, as well as with some planning on what future work needs to happen. For those folks that can't be stabilized via the call center, the first line of defense shouldn't be police unless there is an absolute need for public safety. It should be a crisis mobile team. In SAMHSA's national guidelines, we look at a crisis mobile team as a licensed clinician and a paraprofessional. It could be an EMT, it could be a peer, it could be a behavioral health tech, it could be a case manager, could be an RN, could be a number of other people. That two-person team increases safety, allows people to work more in community, and helps double the chance of engagement. And what we do tend to see in a strong community, about 70 to 75% of the folks that are seen by a mobile team are able to be stabilized and remain in community. And those folks that can't stay in community because of safety issues or because of acuity issues probably should be going to a crisis receiving center, which is a behavioral health focused, substance use disorder focused facility that can ensure safety and security for those folks with high acuity. In the absence of this, really what we start to see is we see people calling 911 instead of 988. In the absence of this, we see people calling law enforcement instead of crisis mobile teams. In the absence of this, we end up seeing people getting their primary crisis care either in jail as a result of a misdemeanor charge that's been placed upon them because of their behavioral health issue, or in an emergency department, which once again, absolutely perfect for injuries, disease, chest pain, car accidents, probably not quite as strong because it's not built for behavioral health crisis. So if we take a look at how the system flows in the majority of states, actually every state, majority of counties in most states, really what we see is crisis begins either with law enforcement or 911. Somebody calls and says, can you do a welfare check? Can you call? I hear somebody attending to some internal stimuli, yelling out on the street. I've got some concerns. I've got somebody who appears to be a little bit out there at my store and refusing to leave. I've got a friend who's talking about suicide. It starts with 911, and the clinical pathway that we tend to see is the police either book people in jail, they take them to an emergency department, or in a third case, maybe they don't have a mandate to go ahead and take someone somewhere, and they just leave them in community without the appropriate resources. Once somebody does hit that emergency department, they can languish for days. You know, we see on average a lot of states with 36-hour plus lengths of stay, which we would call psychiatric boarding, in emergency departments. And really what we're looking to do then in that ED is connect people to care, which usually comes in the form of limited capacity acute care. Most of your communities do have access to inpatient beds, and I'm actually betting that most of them right now are full. So getting somebody into that facility, they might be languishing days and days waiting for that bed to open. And in those days, a lot of things happen. People either get a little bit better and just refuse care and say, I'm leaving. They get referred to some other level of care that may not be appropriate. They leave against medical advice. Actually, you might be surprised at how many people actually just walk out the door, never checking in with somebody and returning back into community. So in Arizona and in Georgia and some other states, really what we wanted to focus on is what if we went ahead and stopped that psychiatric boarding? What if we did something different than looking at a physical health emergency department as being the solution to a behavioral health issue? What if there was something else? And really what we started to focus on was these mobile teams and these crisis facilities. So in Arizona, which is seen as an exemplar in these types of services, calls were still coming into 911 and police, but the police then had another option as opposed to jail. They had another option or disposition in their back pocket as opposed to an emergency department. They could call a mobile crisis team to come over and take over care. I'm going to talk about how often that happens in Maricopa County. Or if they didn't feel that a mobile team was the appropriate level of care, appropriate support for somebody in a behavioral health crisis, they can bring them to a crisis facility. And these crisis facilities say yes 100% of the time. So in Maricopa County, for our 4.4 million people, we have 3 large crisis receiving facilities that say yes 100% of the time when law officers go ahead and bring somebody to the back door. And we get them back out on the street within 3 to 5 minutes on average, back doing patrol, back doing public safety, which they're uniquely qualified to go ahead and be able to do. Now, once somebody hits into the system here, we're either able to stabilize them and return them back into community, connect them to additional resources, or what we find is about 9 to 11% of the time, somebody has a situation that's going to require longer term hospitalization. And we really would consider longer term hospitalization anything after maybe 3.5 days. And they're going to need to go into some of those level 1 psychiatric acute hospitals, which really probably specialize more in an 11 to 15-day length of stay. But once again, that's usually about 9 to 11% of the people in crisis. The majority of folks actually are discharged within the same day that they come in. And about 70% of those folks that need to stay a little bit longer discharged within 3.5 days. So it's making sure that people are getting the right level of care right off the bat. not going to the emergency department and getting transferred over and then coming into here, is we're going to try to access this service as soon as possible via walk-in, via other referral. Now, we've been doing this for years in Maricopa County, probably heavily since about 96. But really what we started to focus on is we think the diversion away from the jails and the emergency departments is great, but what if we could divert it away from 911? What if we, we're never going to have an officer involved in a case that 911's not involved in to begin with. So if we can avoid 911, unless there is an issue of public safety, we're kind of bypassing this system. They're probably not going to be hitting EDs. They're definitely not going to be hitting jails as a result of a behavioral health issue, but we need a separate pathway that comes in. So 911, absolutely perfect for public safety threats, for fire, for ambulance service requirements, absolutely geared toward that. But can we have something that is analogous for behavioral health substance use disorder crisis as well? So really had some focus on creating a 3-digit number. There's a lot of discussion as this started coming through FCC and all the meetings with government that you needed to have a discussion to get that approved about what that number would be, and they settled on 988. And the goal then is, if this is analogous to 911, they can be doing dispatching. They can still refer people into EDs for a medical emergency. They still can't coordinate with 911, and I'm going to show you how that one works in a bit here. If you need police engagement, but primarily it should be call center stabilizing 90% of the folks they talk to, sending mobile teams for the 10% that they can't. The 30% of the time a mobile team can't stabilize somebody, the first option should be a crisis facility. And once again, 90% of the folks coming into the crisis facility are returning back to community within 3.5 days, but those that can't probably should be coming into that limited capacity acute care. So that's the focus that we tend to look at, that we want to be moving toward. And while no state's doing it perfect, there are some states that are moving forward with that, and there are some counties in California that work on that. So I want to just show you something here just for a little bit of a reference. This is the future state of the system for the state of Oregon. RI did consulting to help them redesign. They gave me permission to go ahead and utilize this. And really what we need to understand is that 911 is always going to be there, because we're always going to have those public safety, physical health, fire related issues. 988 has to work in conjunction, because there are going to be calls that come into 988 that really are more appropriate for 911. There are going to be calls coming into 911 that are really more appropriate for 988. So this is the flow system that they have that includes all levels of care. Call comes into 911 and really is more appropriate or needs a co-response with behavioral health team. They're going to go ahead and transfer and work that through. Conversely, if a call comes in for 988 that really is more appropriate to either work in conjunction with or exclusively with 911, there's going to be coordination of care. And then you can end up seeing that they've got a level system where 4P, 4 means I need face-to-face intervention. P means I need police, face-to-face intervention with that 4. I need medical care. Level 4 means face-to-face intervention. I need police and clinician or clinical support. Level 4, I need face-to-face medical and clinician. Or level 4 is I need face-to-face just a clinician. And then this system here, once somebody accesses this system, that system is going to support them in getting to whatever type of level of care they need after that, whether that's referral to community health agencies, inpatient psychiatric, going to the crisis receiving center, or at times if somebody does end up in jail as a result of a felony or another reason officers might need to arrest, or if somebody does have a concurrent medical issue or something that does require physical health evaluation, they would certainly go into the emergency department as well. So the reality is what we're looking at here is an integrated system of care that once somebody connects in with either 911 or 988, the system steps in to say, we're going to go ahead and cover this case until we get to a final disposition. And actually, there's even more flow sheets of what happens when people start to come out of this. So I want to talk about a little bit about the impact that this has in Maricopa County, because there's a lot of benefits and a lot of reasons why Maricopa County in Arizona was seen as kind of an exemplar of it. It wasn't just because of the feel-good nature of the work that we do. It's really because of the outcomes that we've got. So what we see, the crisis now difference is we start to lean into being able to provide the right type of care through call center, mobile teams, and facilities for everybody in our community, regardless of age, regardless of where they are. We start saying that we fit people better to their clinical needs. If I look at crisis work as a ladder, and I've only got 2 rungs, outpatient and inpatient, there might be 4 feet of gap in between that. And people might be getting pushed down into outpatient care that needs something more, or people might be getting pushed up into inpatient care that would benefit at a different level of care. When we're able to align what their crisis and their clinical presentation is with the right level of care, we get a lot of benefits. And we tend to do that 6 times better than average in Maricopa County. We do end up saving as a result of being able to divert folks from the jails, giving quick handoffs for police, helping them bypass emergency departments where they can actually, work wall time and sit with somebody for hours waiting for them to accept. We have worked out with Phoenix Police Department that they anticipate Maricopa County and the 32 jurisdictions are saving about 37 full-time equivalents of police officers to go back to their role of public safety. The fact that we divert away from emergency departments, or if someone does hit an emergency department, they're staying less than 4 hours on average. We're saving 45 years combined for the tens of thousands of people that access the crisis system. If they had hit an ED, they would stay there a combined 45 years if we had the same lengths of stay in emergency departments as we see in Arizona. As a result, though, we're saving $260 million in lower overall health spend. Most of that is coming from the fact that we don't hospitalize people in longer-term inpatient psychiatric hospitals at the same clip that we see in other communities. We save $37 million for the emergency departments that generally tend to lose money when a behavioral health patient or guest hits their doors. And the fact that we're doing the right thing is just absolutely priceless. So the concept is Arizona started to move into this just because of a lawsuit that came out in the 80s. We stayed doing it because we started to see these overall economic benefits while doing the right thing. So I want to talk a little bit about some of the numbers that we end up seeing. So this is for Maricopa County. So in 2022, it took over 218,000 calls, close to 219,000 calls, probably fairly close to the number of calls that Dee Dee Hirsch was taking and Contacts was taking in Los Angeles County during that year. But remember, we have 2.5 times less people. So overall, per capita, we tend to get more calls in Maricopa County go through our crisis call center because we make it easy to utilize. We make it very well published. We provide very good quality service when people call that. And it has become, if you've got anything that you're not sure what to do, you call the crisis call center and let us support you in figuring it out. In December of 2022, our average length on the calls were 12.9 minutes. In 2022, the total number of calls diverted from PSAPs, which is basically 911, your public service access point, to the 988 call center was 11,000. That's 11,000 people that didn't know where to go to that called 911, and 911 said, I know where you should go. You should talk to one of the clinicians, one of the professionals over at the call center. They made that transfer, did a warm handoff with good outcomes. In 2022, they dispatched about 27,000 mobile teams to go into community where people live, work, and play. About 12.5% of all those calls came in. And what was interesting about that is out of those 27,000 calls, 5,200, the call to 988 to request a mobile team came from law enforcement. We said, look, I'm going to stay out here for a little bit. Why don't you come out, send some clinician, send a peer as a team, and go ahead and support this person out in the field. That way I don't have to find another disposition like emergency departments, jails, or the crisis facility. In conjunction to that, about 3% of the calls that did come in to 988 did require the call center to actually coordinate with 911 because there was a public safety or a health issue that were going on with that. So I want to just talk a little bit about mobile team statistics. So once again, I'm not going to say Maricopa County is perfect, but I'm going to say we're at least evolved. We've got a 20-year evolution of where things are going. So some of these numbers may not be achievable in your communities right off the bat, but they can get there, especially as far as percentages. We do tend to see in our mobile teams more adults than we see child and adolescents. Our child and adolescent numbers actually do go up to maybe even 50-50 during months that school starts, especially those when they tend to return back in. In October, there was a 61% community stabilization rate last year, which means mobile teams were able to leave somebody in community 61% of the time that they saw somebody. That number goes up to about 74% in both February and March. Average is probably closer to 70% of the folks that we're seeing. And in December of 2022, 215 times, the mobile teams felt the best disposition for somebody was to come to a facility and get that behavioral health care as opposed to hitting an emergency department or leaving somebody in community. We've got two types of crisis centers in Maricopa County, those that can accept involuntary admissions and those that can't, those that are voluntary, truly voluntary only. So in 2022, there were 32,000 voluntary drop-offs to the crisis centers in Maricopa County. In 2022, there were 40,000 involuntary folks that were dropped off at the crisis centers. It was 23,000 times that came through police. So 32,000 voluntary folks came in the door, 40,000 involuntary folks came through the door, and police were responsible for 23,000 of that. So in December of 2022, we've got 6 centers that are running these types of programs, 3 that take everyone involuntary and voluntary, 3 that take voluntary only, and their police drop-off times average between 2.2 and 3.9 minutes. So very quickly, police get back into the street. If not, they're not going to drop off 23,000 people if it's a hassle or if it's difficult to do so. Out of those folks that come in, those 40,000 that come in that are involuntary, we do a good job of converting them to voluntary. Depending on the facility of these 3 facilities, we see between a 61 and 94% conversion rate. That means somebody either no longer meets the criteria for an involuntary commission or petition holding against their will, or we're able to tell them and talk to them about the value of being an active participant in your own recovery and get them to actually sign paperwork and become a voluntary patient coming in. I'm not going to go through this too much. These are the average types of key performance indicators that we really focus on. And once again, if we do all of these numbers the way that we need to, and we measure against our peers that are doing the same type of work and really work hard to get our numbers as good as they possibly can be, that's when we start to see some of these things that improving. What I also want to talk a little bit about is when you have a no wrong door approach and you accept everybody, you don't get any subconscious bias or bias that starts to come in. And we start to see a true reflection in the numbers of people that we tend to serve. So in 2020, Senator Wyden from Oregon basically said, so how is this impacting disparity, equity, inclusion? And we didn't know. So RI said, well, we can look at our numbers. You know, we admit 35,000 people a year in 10 US states and Australia. Let's take a look and see what our numbers would show. And really what we started to see is if we took a look at the percentage of population in California, for example, 7% of the population is going to be African American, but it is 15% of the folks that we were seeing in our California operations. Overall, if we take a look at, Louisiana, it's 47% of the population is African American, and 60% of the folks that we tend to see, 23%, 37%. But overall, it's about 12% of the population by demographic, but about 27% of the folks that we tend to see. So there is a lot to be said for having an open door that 100% of the time you're going to go ahead and say yes. I do want to talk about changes in funding models that are going to be supported, but I do want to talk about the Arizona funding model because I think it's important. So Arizona is broken into 3 geographical service areas. It's kind of interesting because it's 7, 6, and 8, but there's only 3. We've got the northern, we've got the central, and we've got the southern. Crisis services in Maricopa County, in those 3 areas, they are going to be regulated by a regional behavioral health authority. So we're saying is, look, we want one entity to be accountable in each of those areas for the crisis system. And what happens is Arizona Medicaid contracts with one of these regional behavioral health authorities in each of Arizona's regions. They are responsible for ensuring that anybody, anytime, anywhere has 24-hour access to crisis services within the first 24 hours of their crisis. And it allows them to go ahead and establish the crisis rates, figure out the burdens, to go ahead and create the policies and procedures, to go ahead and ensure that anybody, anytime, anywhere, regardless of their age, regardless of their voluntary, involuntary status, regardless of whether or not they're intoxicated or not, has access to appropriate services and isn't relying on jails and emergency departments. So the contractor, the Regional Behavioral Health Authority, this is important. They establish their crisis response system. They make sure that there is a crisis telephone service or a crisis contact center. They make sure that there are mobile crisis services and that there are stabilization services that people can go into when they are in crisis that diverts away from law enforcement, jails, and emergency departments. So really the contractor is focused on this, make sure there's no prior authorization, ease of access, that law enforcement is absolutely involved, lots of collaboration, all data is shared. And this is what the crisis call center mobile teams and stabilization have to do. Our call center has to provide 24/7 capability. It's got to answer the phone quickly, and it's got to be able to work with 911. And we talked about the numbers. It absolutely does. For mobile crisis, that team has to be on site in 90 minutes or less. We average less than 50. That actually goes up a little bit in some of the more rural areas. It has to have the ability to provide an on-site intervention. Interventions are 75 to 90 minutes. The goal is community stabilization. We do a great job of that. And these stabilization programs have to be 24/7. I've got to be able to admit people at 2 in the morning. I've got to be able to discharge them at 2 o'clock in the morning. And they have to have 23-hour observation, which really is kind of like psychiatric emergency rooms. And they've got to be able to report on what their bed availability is. But how that impacts Maricopa County, if we take a look at RI, our facility, our crisis facility, out of the last 27,000 times somebody has shown up to our door, we have said yes and accepted them into our program. So that creates a lot of faith from the community that we are the no wrong door approach. Anybody that comes here is going to get help. I won't jump too much into our funding strategy. Just understand that the state of Arizona pays for the first 24 hours of crisis, regardless of if you've got a commercial plan, no insurance, TriWest, TRICARE, Medicare, or Medicaid. And the reason that they do that is what they've discovered is when they make these low barrier access, everybody gets the right level of care at the right time. That's 6 times more likely to get that clinical care fit to need. It saves them a lot of money and people being shuffled around, ambulance costs, Medicaid folks actually ending up in inpatient hospitals for 15 days when maybe a 3-day crisis intervention would be more appropriate. So what they do in Arizona is all the call centers in Arizona, there's 1-988, 20 million. All the mobile crisis services cost about 35 million. The crisis receiving and stabilization programs across the state, about 110 million. So the state does put in about 165 million money to go ahead and manage that, but it's not all state funds. Get about 5 million from the Substance Abuse Prevention Treatment Block Grant, about 125 million from Medicaid coming through, and what that requires them is about 35 million of Arizona general funds supporting through. The reality is, by doing all of this, by focusing on how it gets financed, by focusing on what key performance indicators we need, no wrong door, law enforcement. What we do tend to see then is a system that is completely integrated, that regardless of where you are, you're going to get the type of care that you need. You don't have to cross boundaries to go ahead and get the support that you need. Now, we are doing this presentation after the fact because there was a technical glitch. So this is the second time I'm doing it. So I don't have time, or there's nobody to give me questions and discussions. But if you do have questions and answers, feel free to reach out to the CARE MHS info@cars-rp.org, and they'll be able to connect you with me or connect you with somebody that's going to be able to answer what those questions are. So I want to just go ahead and be able to say thank you for attending today, and I hope you got some value out of what we've done today.